Heart failure continues to be a major cause of morbidity and mortality in the United States, and then there's the cost. Well, one of the big contributors to this is something called sleep-disordered breathing, and in the January 20th, 2015 issue of JACC, it's something you may not necessarily be having on your radar all the time: mechanisms and clinical consequences of untreated central sleep apnea in heart failure. And I am with William T. Abraham, MD, Professor and Director of the Division of Cardiovascular Medicine at The Ohio State University in Columbus. First off, thank you for this paper because it is a subject that is of great interest considering how widespread this is. Give me the data first off as to why this is an important conversation.
Well, it's important because sleep-disordered breathing is the most common comorbidity in our heart failure patients. About 75 to 80% of heart failure patients have some form of sleep-disordered breathing. About half of that is predominantly central sleep apnea.
When did we start making this connection between central sleep apnea, disordered breathing, and heart failure?
And, you know, the connection was first made almost 2 decades ago in a classic paper from Shahrukh Javahari, then at the University of Cincinnati, but it went largely ignored by the heart failure community until now.
So I was just going to say, so we've had 20 years, so everybody's taking care of it, and there's not a problem, right?
Yeah.
Not the issue. Oh, geez. So a number of risk factors have been identified for the development of central sleep apnea. What are some of those? Because you talk about those in this paper in JACC.
Yeah, absolutely. So central sleep apnea is prevalent among heart failure patients. So having heart failure alone really is the most significant risk factor for developing central sleep apnea. And unlike obstructive sleep apnea, the typical things that we think of, like obesity, snoring, big neck size, really don't go along with central sleep apnea. So one needs to have a very low threshold for testing patients in order to make this diagnosis.
Well, CSA is often not identified by clinicians because of its subtle findings. They kind of become lost in all of the findings that a heart failure patient has. Is that an issue?
It is. The symptoms of central sleep apnea and the symptoms of heart failure are overlapping. So when the patient comes to your clinic and they're still complaining of fatigue or tiredness, maybe they fall asleep in the middle of the day, we often attribute that to the heart failure, but that may be undiagnosed central sleep apnea.
How do you diagnose this?
Well, the best way to diagnose any form of sleep-disordered breathing is with a sleep study. Typically, polysomnography in the sleep lab is considered the gold standard, but there are now simple home testing devices that can allow a diagnosis to be made in the patient's home.
Now, for the longest time, apnea was really a problem because there wasn't a whole lot of treatment. That's really not the case today, is it?
It's not. There are evolving, emerging therapies for sleep-disordered breathing. Certainly, mask-based therapies such as CPAP have proven to be effective for obstructive sleep apnea. And now more advanced forms of mask-based therapies such as adaptive servoventilation or ASV, and some investigational implantable devices that deliver transvenous phrenic nerve stimulation to regularize breathing pattern and avoid the apnea are also coming down the road.
And some were pretty clunky in the old days, but don't we have some treatments today that are a little less bothersome for the patient who's trying to sleep after all?
We do. Mask-based therapies are much better tolerated today than they were a decade or two ago. The devices are better, the masks are better, the way the therapy is delivered is better. And again, there's now this whole explosion of new technologies and new investigation around alternative forms of therapy, such as implantable devices.
If you do a good job of recognizing it, diagnosing it, and starting to treat it, how is it going to affect the heart failure symptoms?
Certainly we know that treating the sleep apnea improves quality of life. It makes patients feel better. You know, we're still gathering data, and we would ultimately like to prove that clinical outcomes, morbidity and mortality, are improved as well. And the hypothesis is really, well grounded. There is a clear association between central sleep apnea and poor outcome in heart failure patients. If you're a heart failure patient with sleep apnea, your likelihood of dying within the next year is increased by 50%. compared to a heart failure patient without sleep apnea.
So what's the pathophysiology? What's the connection here between apnea and heart failure?
Yeah, so there are a number of connections. Most of what occurs in the setting of central sleep apnea is deleterious to the heart and the circulation. But first, how do heart failure patients get central sleep apnea? They get it because heart failure patients tend to hyperventilate. When they hyperventilate, very subtly, they essentially blow down, reduce their PaCO2 below the apnea threshold. And then the central respiratory centers tell the rest of the system to stop breathing until that CO2 level rises again in the blood and in the brain so that it signals the body to breathe again. It's this cyclical, periodic pattern of breathing that in the extreme form clinicians know as Cheyne-Stokes respiration. But in most patients, it's a very subtle thing, but yet it has severe consequences. When you have these apnea episodes, you have activation of the sympathetic nervous system, hypoxemia, arousals, you have an increase in myocardial oxygen demand at a time when myocardial oxygen supply is reduced, and all of this is bad for the heart.
Oxidative stress would play a role too.
Absolutely.
So clinically, how can we bring this to the fore? Stop assuming, I guess, that the general practitioner is going to look for it or find it. We've got 20 years of knowledge. How do we put it to use?
So now we need to begin to apply it, and I think we've got to rely first and foremost on our subspecialists, our cardiologists, and hopefully the message will filter down to the primary care community as well. But we need to begin to screen our heart failure patients routinely for sleep apnea. You know, we don't see a heart failure patient that we don't screen for coronary heart disease.
Right.
So similarly, given the high prevalence of sleep apnea, we ought to be screening all of our heart failure patients for sleep apnea. We looked at the Medicare database just a few short years ago, and we found that only about 4% of heart failure patients nationally were screened for and diagnosed adequately with sleep apnea. 4% compared to a prevalence of 75 or 80%. We've got a big gap to close here.
So is the screening a complicated procedure? Process?
It's not. The screening is relatively straightforward, either with an in-lab PSG polysomnogram or now with the use of home diagnostic tests that can very simply deliver the diagnosis from the patient's own home.
I was saying that we didn't, I think in the years that we've been doing this, I'm not sure if we've done an entire video on this yet, so I'm really happy that we had a chance to talk. And this is in the January 20th issue, 2015 now, of Jack for CardioSource World News. I'm Executive Editor Rick McGuire.